Hello and welcome to Everyday Medicine. I'm Dr. Luke, and I'd like to thank you for joining me on this podcast series where we share conversations with colleagues exploring their special interests in medicine and bringing insights, ideas, and advice which I hope will be applicable for our medical practices. In this podcast, we're talking with an expert on early onset cancer. But before starting, for Australian audiences, listening does give you eligibility for your CPD, so log in and add this as an activity. And you may also consider journaling, reflection, and adding to the review and performance section in your CPD. Well, Australians in their 30s and 40s are experiencing unprecedented rates of at least 10 different cancers. Between the year 2000 and 2024 for 30 to 39-year-olds, early onset prostate cancer increased by 500%, pancreatic cancer by 200%, liver cancer by 150%, uterine cancer by 138%, and kidney cancer by 85%. Australia is a world leader when it comes to bowel cancer, and again, since the year 2000, the rate of bowel cancer in 30 to 39-year-olds has increased by 173%, and the stage the cancer is at when diagnosed is often advanced. DNA mutations in young onset colorectal cancer are very specific, including those involving mismatch repair genes and the p53 tumour suppressor gene, suggesting particular factors or exposures might be implicated. Now, although the cause for young onset cancer is not known, experts believe environmental toxin exposures may be interacting with specific vulnerable genes to cause malignant changes. So a person with non-vulnerable genes exposed to the same toxin would be unaffected. The Human Exposome Project is documenting and studying these exposures and encompasses environmental factors as well as lifestyle and the connections and interactions in an attempt to explain the causes of different diseases. Other factors considered relevant to the increased onset of young cancers might include 1. Childhood obesity and increasing obesity in young adults. 2. Alteration of the microbiome through antibiotic use and eating ultra-processed foods, as well as through caesarean section. So being born by caesarean section could result in the acquisition of a microbiome different to those born vaginally. Interestingly, E. coli colonization of the colon at an early age may be relevant in this respect by way of exposure to colibactin, a potentially mutagenic bacterial toxin produced by E. coli. 3. Microplastic exposure, including polychlorinated biphenyls and polyfluoroalkyl substances, which are found in non-stick cookware, food packaging, and some cosmetics. These have been referred to as forever chemicals because of their very long environmental persistence. While thinking about this emerging problem, I was curious to learn more about the trending incidents and to seek advice regarding how we should be counselling our patients regarding appropriate recommendations for the age of entry to cancer screening programs. It was a very special honour to have Professor Keefe from Cancer Australia accept my invitation to be a guest on the podcast. Professor Keefe is the CEO of Cancer Australia and an honorary clinical professor in the School of Medicine at the University of Adelaide. She has enjoyed an illustrious career as a medical oncologist and professor of cancer medicine and has a special interest and expertise in gastrointestinal toxicity of cancer treatment, supportive care in cancer, and both medical leadership and health reform. Her pedigree of publications, awards, and commendations is enviable, and her commitment to improving cancer outcomes through her clinical work, professorship, and role at Cancer Australia really is exceptional. So I'm so pleased we can welcome her to the podcast. All right. Thank you very much. Professor Keefe, I'd like to thank you for joining me on Everyday Medicine. It's such an honour and a privilege to have you as a guest. And you're the CEO and head of Cancer Australia. And as I said in my little preamble before we started recording, I heard you talking with Norman Swan about the increasing incidence of cancer in young Australians. And I just felt that I had to invite you as a guest to talk about this very, very important subject. And we're seeing that Australians in their 30s and 40s are experiencing unprecedented rates of at least 10 different sorts of cancers, from prostate, pancreas, right through to bowel cancer and breast. So I'm very excited to be talking to you about that subject in a moment. But before we lead to that, may I ask you a little about your journey into this position as CEO of Cancer Australia. Take us through this. How did you get to this position, Professor Keefe?
Well, thank you very much firstly for inviting me on your podcast. I'm delighted to be here. And yes, it's always fun to talk about how one got to somewhere unexpected like this. So I'm a medical oncologist by training, and I have a doctorate in gut toxicity of cancer treatment. So I spent a lot of time in gastroenterology as well. And I've always had a big interest in supportive care in cancer. So the side effects of cancer treatment. And so I started off in gut toxicity, and then I moved into general toxicity. So I had a career as an academic medical oncologist doing research into oral mucositis and GI mucositis side effects of cancer treatment and looking after cancer patients. And then I had a little bit of a detour into health reform. And then this role came up, and it perfectly combines my interest in the people who have cancer, in the treatment of cancer, and in ensuring that the health system is operating at its peak. So I've been in this position now for 6 years. I've just started my third 3-year term, and I think it's the best job I've ever had. And I hope that we're able to make a bit of a difference.
Well, thank you for steering Australians to a better health outcome. I really appreciate having you with us. Tell us a little bit about the role of Cancer Australia. I don't know that all doctors understand exactly what you do.
Yes, Cancer Australia is what we would call a boutique agency in the Commonwealth Government. So we're in the health portfolio and established, I think, in 2006 by an Act of Parliament, the Cancer Australia Act. And our role is to lead the cancer sector across Australia to improve cancer outcomes for all Australians. So it's a job that involves working with everyone in the cancer sector, the governments, the researchers and clinicians who work in cancer, the advocacy groups, and the people affected by cancer themselves, to work out the best ways to improve cancer outcomes.
So in Cancer Australia, as part of your monitoring cancer incidents, and this is how we've become very aware. Anecdotally, we've seen younger people getting cancers. In my field, in gastroenterology, we certainly have. But you're looking at statistics as well, and then you're being able to draw this increasing incidence of cancers in young people to our attention. Is that right? You're sort of also scanning the incidence and prevalence.
Yes, so the data are actually held by the Australian Institute of Health and Welfare, AIHW, but Cancer Australia does monitor the data in cancer to look at which cancers are prevalent, and we also look at issues such as where research money is spent in different cancers and different stages of the cancer journey. And we do actually have some grant funding that we give out for specific cancer research projects too. One of our functions is to horizon scan for what's the next big thing in cancer. And so over the last 6 years, while I've been involved in Cancer Australia, we did a lot of work in the COVID pandemic around how you would manage cancer during a pandemic, how you make sure that patients still present with their cancer symptoms, because we knew during the lockdowns there would be a reduction in presentation, which might lead to a reduction in early cancer diagnosis, which might lead to an increase in later stage cancers further down the track. So we were very proactive then. We have also been involved in developing the lung cancer screening program, which just launched earlier this month, a very innovative new program for detecting lung cancer early. And we also, in the last couple of years, developed the first national Australian cancer plan, looking at how to improve cancer outcomes for everyone in the country. So that makes you look at disparity. It makes you look at where the cancers are, who's getting them, what's happening with them, how they're treated, what the research is, and then try to work out what we need to do to make sure that everybody in Australia has the same excellent outcomes as we can manage in our major centres. And as part of that, we have been looking at what are the next big things that we need to concentrate on to improve outcomes. And obviously, it's happening around the high-income country world, this increase in early onset cancer, that is cancers in the 20 to 40 year age group that usually would happen in older people. And when that started being flagged, we started looking and investigating and trying to work out what we needed to do.
Tell us about those cancers. What are we seeing in younger people? What are you noticing?
So the absolute numbers of these 10 cancers in younger people are still quite low, but they're higher than they were. You know, as we always say, cancer is a disease of aging. So cancer is much more common in older people, and the older you get, the more likely you are to develop a cancer, such that by the age of 85, 1 in 2 people in Australia is expected to develop cancer. But there are more cancers in this young 20 to 40 age group than there used to be, and they're not the cancers that usually happen in younger people. So we've got this increase in bowel cancer, in breast cancer, in prostate cancer, in some of the gynecological malignancies, in thyroid cancer. And we know that this is odd because these diseases usually take longer to develop and happen in older people. So when we started to be aware of this, Cancer Australia did a couple of things. We actually commissioned a piece of work to look at the actual epidemiology and make sure that these numbers are real, that this is a real effect or a real event. And we also commissioned a piece of work looking at the international evidence for what's causing it. Because until you know it's real and you try and understand the cause, it's very difficult to intervene. We also actually just last week launched a new research grant specifically looking at early onset cancers. So what we try and do, although we don't have a large amount of cancer research funding, we have enough to steer the research community a little bit into areas that we know need looking at. And this is one of them.
I see. It's not peculiar to Australia, is it? This is across the Western world. So all developed worlds are seeing similar trends, or are we a standout country?
Well, the answer is actually both. So the answer is yes, this is happening in all high-income countries. So our, close colleagues in Canada, the US, the UK are seeing similar sorts of rises. But we have the unpleasant distinction of seeing the largest increase in early onset bowel cancer in the world. Now, again, the numbers are not very high of absolute cases, but we don't want to be the early onset colon cancer capital of the world.
I think that's very interesting as well when we think about it from the clinician's point of view, because there was a tendency for us to see young people with rectal bleeding, I'm talking about people in their 20s, and just argue that it was almost certainly going to be hemorrhoidal, which for the most part it has been that. But now I think as clinicians we're thinking, we perhaps shouldn't make that assumption. We should actually investigate this patient. We've been concerned about being maybe criticised for over-servicing younger patients, but I think we probably have to think about it differently with this new information, even though, as you say, the raw numbers are extremely small. But it's a change that I think we're all starting to consider now and being discussed at our various craft meetings.
You're absolutely right. This is the issue. When I started in oncology, nearly 30 years ago, young people with rectal bleeding did not have cancer. And the problem now is that most of them still don't, but a small number does have cancer. And so we need to shift our thinking about the sort of surgical sieve and diagnostic flow chart for certain symptoms in younger people. And one of the other pieces of work actually that Cancer Australia is doing is working with some general practice researchers in Melbourne to sort of shift that front end thinking and diagnosis and investigation to make sure we don't miss these tumours, because they're still rare, but we must not miss them.
I agree. Tell us a little bit about the current theories about why cancer is happening in our younger population. To just run through, there are quite a few different thoughts that have been put forward. Can you tease that out a little bit for us?
Yes. So this is a really interesting area, and we don't have a definitive answer, but there are multiple possibilities. And as you know, it takes quite a long time for a colon cancer to develop, for example. So the changes that are leading to it developing in a younger person have got to be starting early.
Yes.
And there are questions about nutrition, about environmental exposure, about the microbiome, which is obviously a really important issue. You know, what's the microbiome like in early childhood in these people who are developing early cancer? And there was a paper recently talking about colobactin producing E. coli in childhood being associated with early onset cancer. And I think you mentioned Dr. Buchanan and his research into the exposome. I mean, the exposome is, I love these omes, you know, there's an ome for everything, but this is basically what you've been exposed to. And yes, there is going to be something in there, or maybe multiple somethings in there, that has potentially brought this about. And it's going to be quite difficult to tease out, and even more difficult to actually intervene.
So we're really looking at cohorts of Australians and people from the developed world born in the 1980s and 90s. We don't know about those from the 2000s on, but probably it's going to be the same for them. We're going to see that maybe come into the future. But they're the group that have been exposed to something. We're not quite sure what it is. What about the Exposome Project? Can you tell us a little bit about that? That's an exciting area. What's happening there?
Well, it is an exciting area, and it's basically looking at the exposures alongside the genome to see what changes are happening that put you at risk of complex diseases like cancer. So it's an emerging field. It's slightly beyond my deep understanding, but I think it's looking, you know, it's using modern techniques and data and analytics to enable us to see how cumulative exposures of different sorts affect the molecular processes that contribute to disease. And so it's a very complex area. And it's what I was saying before. I think that if we discover that there are some early life dietary patterns and changes in the microbiome that are causing some of these issues, then how we intervene in a cohort manner, if this is a cohort effect, which is looking likely, that's going to take some doing. One of the problems, as you would know as a gastroenterologist, with the microbiome is it's very difficult to determine what's actually normal.
Right.
And what makes it normal, and then how you change it from abnormal to normal at a stage that will prevent you from getting a problem later on. So, I mean, we have to do it because it's really important, but it's not going to be easy.
No. My feeling about it is that, as you say, there isn't perhaps a normal. There's just lots of different variations depending on the human you're talking about, and maybe no two humans are the same. They probably aren't, even though you may have a twin, may not be the same. But it's got to be influenced not only by exposure when you're born through the birth canal, cesarean, breastfeeding, etc., but also your diet. You're going to have a very big factor, an influence on it, antibiotic exposure, so many things. But it does seem to me often it's simplified, I think, on commercial terms. People simplify the microbiome for maybe commercial gain, but there's so much that we're not really sure about still. It is a fascinating area. I'm also intrigued to know whether the cancers we're picking up in younger people are more right-sided or left-sided. Do you have any data on that in regard to colon cancer, for example?
Goodness, I don't actually. I'm sure there is a shift, but I haven't got it at my fingertips. Worth checking.
Yes, because over the years we've seen, initially when I was training, it was left-sided cancers are far more common, and now they're all pushing toward the right-hand side. And I know from my own personal experience with polyp retrieval, most of my polyps are now more so in the transverse colon and right colon. I'm not sure if that's the experience of other gastroenterologists, but it's something that I've noticed in my clinical practice that's changed in the last 20 years. And of course, during this time, we're more obese, there's much more sugar exposure, there's all sorts of other things, more processed food probably. There's lots of other dietary factors that I can just put my finger at straight away and say, well, maybe it's relevant, maybe it's not. We don't know, but hopefully that'll become evident.
That raises a very interesting point. And the question of the increase in obesity is raised, but these cancers aren't appearing in obese people.
No.
It's more general than that.
Yes.
And
from childhood obesity, though, Professor Keefe, is that a factor that we're seeing?
I'm not sure we've actually I'm not sure we
chubby,
actually know whether these are people who were
but
obese in
chubby.
childhood and no longer obese. But we haven't shown an obesity link for these early onset cancers yet. So I think that's another area that still hasn't been fully
Yes.
explained.
Yes. It's complicated, isn't it?
It's complicated. And, in some of the other cancers, I know you're a gastroenterologist and that's the main interest, but, some of these other cancers may be increasing in number due to better diagnostic techniques. So, for example, thyroid cancer, which has gone up a lot in percentage terms, but not in real numbers, is probably largely due to better neck imaging.
Yeah, better diagnostic.
Yeah. So there's a combination, and of course, in thyroid there are some that wouldn't have done you any harm if they hadn't been diagnosed. So we've got this issue around overdiagnosis that comes into it.
Yes.
But younger onset cancers do tend to be more aggressive. So we've got to balance out all of those.
And I guess
prostate
is the other one that's come in for a lot of discussion about relatively indolent prostate cancer, and we're diagnosing that, I think, with increased sort of interest, because men's health, I think, has become talked about a lot. A lot of men are now talking about prostate where they never would have, they just would not have raised this. But I think we're now thinking about that a lot more, maybe finding more indolent cancers. That's one that I think has increased maybe up to 500%. But also we've got pancreatic cancer and, as you say, renal cancer. There's lots of other cancers that have more aggressive pathways that we're seeing.
Yeah, look, prostate cancer is very interesting because yes, there is a lot of indolent prostate cancer, but in the younger men, prostate cancer is a nastier disease. So where prostate cancer is happening in younger people, that is actually a problem.
Yes.
Picking up indolent cancer in older men is not such a problem because they're the men who die with it, not of it. But it's the younger ones are more aggressive, and therefore we have to take that more seriously. So there's a problem in the difference between the natural history of the disease diagnosed earlier versus late.
Yes, that speaks to your point that, younger cancers tend to be more aggressive, yes. Do you think, based on what you're bringing to our public knowledge about this change in cancer incidence in younger people, our screening programs should now be undergoing some review and change? What should we be doing there as clinicians? It's perhaps not clear yet, but what do you think there?
Well, this is a really interesting topic because the thing about a screening a couple of things about screening programs. One is you've got to have a screening test available that's cheap and easy to do and points you in the direction of having the cancer. The second thing is that it's got to be cost effective. Now, I don't mean that we won't spend money on health interventions. What I mean is it's got to do more good than harm. And there's an age cutoff at which the number of cancers you'll detect is not outweighed by the number of problems you will cause with unnecessary investigations. So we constantly have to balance what age you start a program with the amount of harm as well as the amount of good you do. So with the recently launched lung cancer screening program, we're starting at 50 because that's the age at which we find enough cancers and we don't cause too much harm. We've lowered the age of bowel cancer screening to 45 because it's now evident that at that age, you're getting benefit over harm, but we can't lower it to 20 or 30 because we would cause more harm. We would probably kill more people with all the over-investigation and complications of diagnosis and surgery and whatever than we would save by finding it earlier. And you just can't do that. Prostate cancer is difficult because we don't have a really good screening test that is able to be used across the whole population. There are some new prostate cancer guidelines in development, but it's still tricky with PSA. And, we're not there yet with that screening program. And again, with breast cancer screening, the program starts at 45 or 50, but you can have I think it's 50, but you can have a mammogram from 40 if you request it.
Yes.
But any younger than that, and the radiation damage is more of a problem than the diagnostic. So it's a constant balance. So screening is not the answer for this particular problem.
Yes, I think it's a very good point. And maybe as clinicians, we just have to be very attuned and aware to this data and have a high index of suspicion. I mean, it's, as you say, it's a balance, isn't it, between over-investigating and investigate with intelligence and sensitivity. But it's going to be fascinating to see if we have some other screening tools that come out, like stool DNA analysis, for example, maybe some other tests that will come out that won't be so expensive and won't be invasive and might lead us to, for thinking about bowel cancer, lead us to early diagnosis and investigation. Where do you see the future of this incredibly important subject?
So that's a really good question. I think you're right. I think that we need to use all the knowledge we have of all the different analytics and clever tests to enable us to detect cancers earlier in younger people. As you know, there are now various breath tests you can do and liquid DNA, etc. We have to be careful there because although there are some fabulous tests that can pick up, 50 different cancers 5 years before you would have had symptoms, the difficulty is what do you do with that information if you come across it. So we have to be careful that we don't do anything dangerous for people. But I think you're right. We have to educate ourselves as the medical profession, about how to respond to symptoms in young people that in older people would be associated with cancer and in younger people didn't used to be. So we have to shift our thinking there. We have to always remember that persistent symptoms are a problem. So we should never dismiss somebody who has persistent symptoms that they're concerned about, because the number of times you hear a young person diagnosed with cancer saying, I told my doctor for X number of months or years about this and they dismissed me and told me I couldn't have cancer. Nobody is too young to have cancer. And a short-term symptom is usually not cancer. A persistent or recurrent symptom needs to be taken seriously.
Yes.
We need to sort out the causes. We need to research the interventions to treat the cancers that occur. We need, in the future, I think the use of genomic testing is going to be valuable. At the moment, we would do genomic testing at diagnosis only on cancers where there's a known somatic mutation that might influence the treatment. In the future, I think that we are going to need to consider some sort of genomic testing at a given age, maybe 25, maybe 30. This is at future years. I'm not advocating we do this now, but as the evidence develops for ability to intervene, we need to be ready to test in a different way. So I think there is going to be a change in screening. I think at some point in the future, a person in their 20s or 30s will have an assessment of their screening needs for life, and they will have a family history and a history taken and a genomics analysis, and we'll look at how to tailor their screening, because they may not need, bowel cancer screening every 5 years or 2 years. They may not need breast cancer screening as often, or they may need it more often because of risk. And then we tailor that program and we follow that person through their screening journey. We're not there yet, but I think that's where we're going with the advances in technology and the advances in genomics and exposomics as well. I mean, if you can get the exposome incorporated into that, you can tailor the screening journey even better.
Oh, Professor Keefe, thank you so much for taking the time to discuss this with us today and for giving us a very good précis of where we are at the moment, and as you just have a wonderful glimpse into the future.
It's an absolute pleasure. Thank you very much.
And where we're going to head in terms of our diagnostic skills, it's going to be a brave new world in the future. Professor Keefe, thank you so much. We really appreciate your time, and it's a great honour to have had you as a guest. Thank you so much. I'd like to thank you all for joining me on this podcast with Professor Keefe on the rising incidence of cancer in our young. This is a very concerning subject, and I do hope that research will shed light in the future and help us prevent these terrible tragedies in our young Australians. Please join me next week. We have another very interesting guest and clinical problem to review. And during the podcast series, we will be covering a wide range of topics across many special interests. The discussions are not intended as specific medical advice for patients, but as general information only and reflect the opinions of the guests interviewed. And requests for new topics to be reviewed and comments about the conversation you've listened to are welcomed and may be emailed to manager@geohealth.com.au.